morning. The Senate Finance Committee will come to order Wednesday, March 4th, 2020. Members, today we have one bill on the agenda, Senate File 3813. Senator Ralph, welcome to our Finance Committee. The Coronavirus Disease 2019 Public Health Planning and Preparation Appropriation. And before we start with you, Senator Ralph, members, this is how it's going to work. We're going to hear the testimony from Senator Ralph on his bill. And then I think there is a technical amendment. We'll vote on that. Then we are going to have testimony from MMB, from MDH, and also from the President and CEO of the Minnesota Hospital Association and the Acute Care Operations, also the Director of Infectious Disease Epidemiology, Prevention and Control Division. So we have a very full morning and I would like to get to your questions, but I think what we'll do is try to keep some of the questions after both commissioners, and then after the other testifiers will have a chance to ask our questions. So with that, if you could please, Senator Ralph, to your bill.
Thank you, Madam Chair and committee members. We have an opportunity here to get kind of ahead of the curve. The coronavirus is not in Minnesota, to my knowledge, unless something's happened overnight, but we are pretty sure it's coming. So rather than try and play catch up, we felt that it was appropriate to provide at least some kind of financing mechanism that will allow the whole healthcare system to be ready to respond to the eventual outbreak. With that, I would introduce Senate File 3813, and I believe someone would have to move the bill.
Senator Ralph, I do believe you have an amendment.
And I do have an A2 amendment as well.
Senator Benson to the A2 amendment.
Madam Chair, I move the A2.
Senator Benson moves the A2 amendment. Would you like to explain that, please, Senator Ralph?
Thank you, Madam Chair. Yes. What this amendment basically does is there was one piece that we noticed as I was looking through that if, in fact, we do get reimbursement from the federal government, that we feel that since this money that we're going to put in to the contingency fund is coming from the general revenue account, that federal funds that are reimbursed should be available to reimburse the general fund up to the amount, but leaving enough in the account. I believe there's roughly $5 million in there now, maybe a little less, but we would maintain that at $5 million. And the remainder of the money would come back to the general fund. So that's basically what the technical amendment does. It also kind of cleans up the language and has specific statutory references as to what we're doing. This is somewhat unusual in that most of these contingency funds do not have a clawback provision in them, but we are putting one in this one because this is specifically for the response to the coronavirus.
Thank you, Senator Ralph. And for the record, members, we do have a quorum. Any questions on the A2 amendment that is in your packet? Senator Nelson?
I have no questions on the amendment, but I would move the bill for the author, 3813. So I'd move 3813.
Thank you, Senator Nelson. Right now we are on the A2 amendment. If there are no further questions, Senator Benson renews their motion on the A2 amendment. All those in favor say aye.
Aye.
All those opposed, nay. Motion prevails. Any further questions? Actually, I think we'll turn over to Mr. Naumann. If you can explain the fiscal implications of this bill.
So, Madam Chair, now that the committee has adopted the A2, I'll work off of that for the purposes of the conversation. The bill operates off of an existing statute that has a collection of uses for an account for basically public health response to deal with this. This was an account that was established, I think, 2-3 years ago in response to a previous concern about a pandemic, and resources were put into the account. When money is transferred into the account, it does not by statute cancel. It remains there. There is a requirement that whenever that requires the Commissioner of Health to seek any federal reimbursements that are allowed, and if federal reimbursements are forthcoming, to reimburse the account for any federal dollars that are generated in that process. So functionally what the bill does in this, now that you've adopted the A2, is transfer $5 million from the general fund into the account, and then that money can be made available to the Commissioner of Health for a whole series of, we can talk about this if you want to get into that level of detail, of public health responses related to a pandemic or infectious disease.
Thank you, Mr. Nauman. Senator Ingebrigtsen.
Thank you, Madam Chair. Mr. Nauman or Senator, what's the chances, does anybody know, and maybe the testifiers will have an idea because of the states that already are dealing with this, the chances of us getting our dollars back from the federal government. Does there anybody have any idea, or is that just really up in the air if we needed that?
At this point, I believe that what
Senator
we're
Ralph?
doing, I'm sorry, thank you, Madam Chair. Senator Ingebrigtsen I will have, the testifiers will come up and they can probably give a better idea on what's going on since they've dealt with this before with the H1N1 and how the feds responded to that. But I am presuming that at some point in time, probably after we've made the expenditures, that there will be some federal reimbursement, and that's probably why, or that's why we have the additional part of the amendment that includes that reimbursement in the return to the general fund. I would also note that at this point the $5 million is kind of a placekeeper, and that we are probably looking at a larger eventual response in this fund. But that's part of what the testimony this morning should cover.
Thank you, Senator Ralph. That's a perfect explanation on that. Thank you, Senator Ingebrigtsen. Okay, with that, I think Senator Benson, would you like to mention the amendment that could possibly go on? We can.
Madam Chair, and thank you. As we've been working in the healthcare community, we realize MDH has a critical role, and I just want to take this opportunity to say sincere thanks to the professionals in our public health department. We've talked to people outside the bubble here in St. Paul, and just a really exemplary job. And so I want to say thank you to them first. I've also been in contact with our hospital association, and they're figuring out how to be ready. And so I want to make sure that in addition to the MDH money that we're going to talk about today, that there will be money available for hospitals, clinics, and long-term care facilities. But because I'd like to do this through grants managed by MDH, I think it's best that I be in coordination with hospitals, clinics, long-term care, and MDH before I offer any language. But in addition to what's talked about today, we will need some resources for those types of facilities. And so when the amendment language is a little closer to ready, bring that to the members of the committee and make it available to the public.
Thank you, Senator Benson. And so that does bring the discussion that we are going to go ahead with the testimony. Senator Nelson, I appreciate you're willing to move the bill, but I believe after the testimony, we will be laying this on the table for tomorrow's hearing, because we're not quite ready to pass out and to solidify what the needs are going forward. Senator Nelson.
Madam Chair, the motion is just to move the bill, not to do anything with it. So I'm
Okay.
move it to lay on the table or whatever the chair decides.
Thank you. Thank you. Okay. With that, we will start our testimony. Commissioner France and Commissioner Malcolm, if you could please. Who would like to go first? Commissioner France.
Madam Chair, members, thank you for the opportunity to testify today. I just want to provide some overview of the financial and budget planning that we're going to be doing and involving the legislature with. I'm going to talk a little bit about sort of the numbers game, so I may sound cold-hearted, but I'm just here, obviously concerned about the human response and issues that come up, but I'm going to focus today on giving you some information about how we're going to be analyzing and researching this information. So as Commissioner Malcolm will talk about being the lead on this for external offices and the system that we have set up, MMB is the lead agency for continuity planning within agencies in terms of any disruption. We also have the state human resource challenges to monitor and maintain our state human resources, labor relations, and also state employee communications. Okay.
Thank you.
So anyway, with that in mind, one of the things that is being done today, pursuant to the statute, Minnesota Department of Human Resources and Commissioner Malcolm has initiated the protocol for MDH, the Minnesota Department of Health, to access current public health response funds. And so they've initiated that to the various chairs in the legislature, and after that, they will be following up with a request to actually expend some of those funds. But the notice needs to come first to the legislature, and then the request for funds follows after that, according to the statute. One of the things that we've been doing at MMB is to assist in the preparing an estimate for what additional funds we might actually need. And as the Senator Ralph has already mentioned, there is some question about what that ultimate dollar will be, but Commissioner Malcolm will discuss that. One of the things that we're doing is researching likely economic and budget impacts from similar events that have occurred, and also this one around the country. One of the things that you have to look at is what challenges or effects might occur to your revenue stream in a particular state, and we'll be looking at past experiences, but also this current one around the country, because if some economic activity is reduced, then what kind of dramatic impact might that have on the state's revenue fund? So that's one thing that we'll be monitoring on a daily basis. The budget effects obviously is another area. If there's some situation where we have to suspend economic activity of the state or state activity, what do we do regarding the employees and ongoing salaries for employees when they're not able to perform their functions? Obviously, we have salary obligations, labor law obligations, so those are issues we'll have to examine as well. As some of you know, Dr. Klumbakidis yesterday testified that it's difficult to estimate up front what the economic effect of something like this can be. We do note that in SARS in 2002-2003, the GDP in the U.S. was reduced by 0.7% for that 1 year. But that was kind of a major global event. Didn't have a lot of effects in the U.S., but it was a major global effect on the economy. So what we do on an ongoing basis, just so you're aware of what we do typically, is every quarter, beginning of April 10th, we will provide an economic update and review. So no matter what happens, we will be doing updates for the economy on April 10, July 10, October 10, and next January 10. But in the meantime, we will be assessing any shifts or dramatic changes in revenue or expenditures that we think are noteworthy, and obviously we'll be providing that information to the response team and the planning team, but also to the legislature, because we obviously have a little bit of time here before the session is over to make sure that we keep that up to date by the end of the session. But assuming this goes beyond session, we would also then figure out some way to maintain an ongoing communication so that you all are aware of what we know in real time as well. So with that, I'll take any questions.
Commissioner France, I think we're going to wait till after Commissioner Malcolm for questions for the both of you. And I'm just going to say, Commissioner Malcolm, that picture is disturbing. Is that really the COVID-19?
That is the virus.
Disturbing.
Good morning, Madam Chair and members. I'm Jan Malcolm, Commissioner of the Minnesota Department of Health, and thank you so much for giving us this time, not only to work on Senator Ralph's bill, which we deeply appreciate, but to give you a little bit of an update and briefing. And because you've got lots of testifiers and I hope questions that we can address for you, I'm going to go really quickly and not talk about every slide in the deck, but I want you to have it as a resource and to be able to contact me or my staff at any time. Just for clarity, Madam Chair, our director, our wonderful director of the Infectious Disease Division at MDH, Chris Ayresman, is here really just to answer your questions. She doesn't have separate testimony from mine. So with that, we'll proceed. The first picture here is of the current state as we know it of the numbers and the global spread around the world and in the United States. And I will just say right up top, these numbers are no longer current. We literally cannot keep up with the numbers as they are changing so quickly, but over 90,000 global cases and over 3,000 deaths. You'll note that the great majority of the deaths are still in China, as are the cases, but the increase in the numbers of cases in countries outside of China is much more rapid. China seems to be stabilizing to some degree, although that's speculative at this point. We don't know what we don't know about remaining numbers in China. But you'll hear it said, and it's true, that the ratio of new cases being reported each day, there are 2 or 3 new cases in countries out of China for every new case that's being reported in China. So it just underscores the global nature of this epidemic. Within the United States, we're now over 100 cases, and those numbers have changed very rapidly in recent days. And as I say, it's really hard to keep up. And the CDC numbers versus the state numbers are beginning to diverge a little bit, just as the states are beginning to find more cases. But this next slide talks about the U.S. a little bit. As of last night, it was 12 states reporting cases. The CDC is reporting 60 total cases within the U.S., including detected within the U.S., so that's distinct from the U.S. Citizens who've been repatriated from other countries where they got the disease in other countries. We're talking about the cases that presumably have been detected here. So Washington State now has higher numbers than what the CDC is reporting. So I'm just to illustrate the quickly changing nature of the numbers here. Deep concern, certainly what we were learning from Washington State, is that this virus, if it has a chance to spread in a community, it can do so quite quickly. And certainly the outbreak in the long-term care facility there is exactly what we feared and expected, frankly, just given what we know about the increased risk that elderly people and people with underlying health conditions are at from this virus. So I'm not going to detail every point on these slides, but certainly can come back to them. I do want to just affirm what Senator Ralph said at the outset. As of this morning, we have no confirmed cases in Minnesota. We have, over the last several weeks, had a number of what CDC refers to as persons under investigation, or PUIs, you'll hear. We have been working all along with our healthcare system and local public health partners and persons who have self-reported concerns that they'd been in China and are ill. So we sent along the way 5 cases down to the CDC for testing. All of those were negative. Since Monday morning, we've had the ability to do testing at our public health lab. Since that time, we've tested 9 persons of interest who meet the screening criteria at this point. And all of those so far are negative. So the really important news for Minnesota is that we now have the capacity to test here, which speeds up and just adds capacity. I do want to make a clear point, though, that while it is the goal to increase testing very broadly as across the country, we do still have a limited supply. So in Minnesota, we have the capacity to test 800 people at current with the supplies that we currently have. The goal is to increase that greatly, and eventually for providers to be able to do testing at the point of care, but we're a ways from that. So as of today, the state public health lab is the only resource that can test in Minnesota. And we don't have infinite capacity, which is to say we do still need to be judicious and targeted in terms of when testing is really indicated. But thought I wanted to share that with you, and Chris Ersman can give you additional details if you'd like on testing criteria and what we foresee in the coming days. This next slide, just a reference for you. One of the key questions is how easy is this to spread? And that is something that's still very much under investigation. And I should say that at the outset, that anything I say should be caveated with as what we know today. It's a fast-changing situation, and we all know that the data aren't complete, and that we'll probably learn a great deal more. And frankly, now that we have the testing capability in Minnesota, we're going to learn a ton from Washington, in the U.S., excuse me. We're going to learn a ton from Washington State. Some of the data coming from European countries, we think will lend itself to better analysis, and really our understanding should begin to increase rather rapidly. But the question of how infectious is this really is determined by epidemiologists based on what they call the basic reproduction number, or R0, as it's known, which tells us how many people an infected person can infect. So if it's 1-to-1 or less, that means you've got a pretty good chance of containing the spread in a population. If the R0 number is over 1, so that one sick person is infecting more people, then that is when community spread tends to become widespread. And the R0 for COVID-19, according to what we know today, is between 2 and 3. So this has got the potential, and we see it playing out to spread rapidly in a population. How dangerous is this? This chart kind of, again, preliminarily, kind of puts this in context of, it's more dangerous than seasonal flu, although as the numbers of cases of illness are better determined, the numerator, or the denominator rather, will probably grow. So that lethality rate, if you will, or that case fatality rate may well drop as more cases are discovered. But as you can see there on that chart, it's significantly less fatal than Ebola, MERS, and SARS, and more so than seasonal flu. But rapidly changing picture there. But critical to say, this is the average population-wide number. The case fatality rates in older people with compromised health, immune systems, is quite a bit higher. So that's where, and it's quite a bit higher for people who get a severe version of the disease. Maybe I'll go to the next slide. What we know, again, so far, globally, is that about 80% of all of the cases of people who test positive are mild. They may not even know they have them, or it's not terribly distinguishable from a cold or a mild flu. So these are cases that likely will not need much medical intervention. 14% of the cases, however, so far have been severe, where the respiratory illness is more severe, and it results in more and more complications. 5% of patients so far have been admitted to the ICU for treatment. And among that population, the mortality rate is quite a bit higher. So if somebody gets severe disease, the mortality rate is quite a bit higher than for those for whom it is a mild illness. So it's just important, when we talk about population-wide averages, that can cover up a lot of important information. So we really are very focused on that subset of the folks who are going to get severe disease, need to be hospitalized, and need intensive care, because that's where the medical care intervention can make such a difference. Just for context, current influenza activity, this is just a chart of this season's outbreak, and just to remember a point I think that hopefully should increase everyone's confidence. We manage a pandemic of flu every year globally and in our state. So that's the good news. I mean, this preparing for and managing big influxes of disease is a basic thing that we deal with in healthcare and in public health, which is not to say that there's not additional things to worry about here. It's always a different situation when we're talking about a virus that's not been seen previously, for which there's no built-in immunity, and we just don't know what we don't know about the virus. But I think it's important for Minnesotans to keep in context that we've had almost 3,000 hospitalizations so far for the flu this season and 72 deaths. So just putting that in context of the novel virus that we frankly expect at some point, but have not seen yet. Pardon me. The other critical point here, though, is that the healthcare system is already dealing with this. And I'm sure you'll hear from other testifiers that the hospitals are full, the ICUs are full. So a concern is if we would get a big bolus of additional cases from this new virus, it would be on top of a system that's already running very, very flat out, so to speak. This picture is really the classic epidemiologic curve of a pandemic. And so the purple is what happens, what a pandemic outbreak looks like without successful public health intervention. And where you see just a rapid increase in cases with very little time and very little ability to kind of absorb that volume in the healthcare system. So the whole attempt here, globally, nationally, and in Minnesota, is to slow down and spread out the expected spread of this illness. And so that's the smoothed out line on the bottom with the lines is what we are seeking to do. And I think you've heard health officials say this at the World Health Organization, at the CDC, and here as well. This is clearly a global outbreak. These cases are going to continue to spread in the world. We think it's highly likely that there will be cases in Minnesota, but the whole goal is to slow it down and spread it out so that the healthcare system can manage this. So hopefully that's a helpful visual for you. This next one also kind of describes that the approach to trying to manage this changes with where we are on that epidemiologic curve. The effort here in Minnesota and in the nation has been containment. So if we find a case or cases, we isolate the people who are sick, we trace down who they've been in contact with, and we ask those folks who've been contacted and may have been exposed to voluntarily self-quarantine to try to prevent the illness from spreading, so containment. But once you begin to see what we've seen now in several states of community spread, where folks are getting the illness without known direct contact with a person who's been ill, the approach has to change. So then you're getting it in the community. You're not getting it from a known exposure to a known person with the illness. So that's when you start looking at things and I should switch to the next slide here. To kind of define what is the approach at these different stages. So again, isolation, contact, identification, and quarantine is the way that we try to contain a handful of cases. When we're seeing community mitigation, multiple cases from different geographic areas, but also different ways that people are getting the disease, either exposure from direct contact with a known ill person or the unknown contacts of where did this come from. That's when we begin to consider interventions, sort of known, you probably have heard the term social distancing, that we encourage people, absolutely encourage people, who know that who are ill to not circulate in the community, but then we consider temporary school closings, recommending postponement of large gatherings, promoting as much virtual commerce and interaction as is possible, et cetera. And then when we're at the stage of pandemic management, where we're seeing widespread transmission, not just pockets of illness, but really widespread, hundreds to thousands of cases dispersed across the state, then frankly, we're in more of a resource management mode with the healthcare system and encouraging people all along the way here, encouraging people to do everything they can to protect themselves and their families with basic precautions that really are pretty successful. But hopefully that's helpful to you to just understand this is what we expect. This is the way epidemics evolve, and there are different things that you do at different stages. So in the U.S. and in Minnesota, we continue to do both, focus on containment to the extent we possibly can, and community mitigation is beginning to be more and more a tool that you hear discussed in other communities. And part of what our preparation is about is to work with community leaders to think about what would community mitigation look like if we need to do that. And again, the goal is to slow the transmission, minimize the mortality, preserve the resources in the healthcare system for that smaller subset of people for whom the disease is more severe and medical interventions can really make the difference. What we've been doing at the state is we've had a joint information center, regular calls and contacts between the communications folks at MDH and the communications folks in our local public health agencies. That's been going for some time. So the flow of information between the state health department and local health departments has been really picking up significantly. Just this week, we've also initiated a joint information center between the public information officers, the communicators in all the state agencies, so that all of us are working with our constituents and using the same resources, the same messages, trying to just make sure that we're getting the best information out through all of our contacts in state government as we can. Just yesterday, we started something we're referring to as a joint coordination center, which is one step short of a declared of an emergency, where we've not yet activated the State Emergency Operations Center, but pretty much the same players are already meeting and communicating so that we're ready to activate the State Operations Center when needed. The Department of Administration is preparing to implement enhanced cleaning protocols at the Capitol and other state buildings, just to do everything we can, following CDC guidance to protect our workers and our citizens. We are, I think I've kind of covered this already, continuing to get additional guidance from the CDC as they learn more about how the spread is happening. They are sending out new guidance virtually every day to help inform care providers on identification of cases, when to test, how to treat. But they're also sending lots and lots of guidance out to care settings, long-term care, home care, daycare, schools, so that those settings know what can be done to prepare and to manage. Mentioned the fact that our laboratory testing here in Minnesota is now online. We are working really hard on the planning with all of these constituents. There are 8 healthcare coalitions around the state, which are organized groups of healthcare providers that work with MDH and local public health to think about preparedness all the time. So these coalitions have been in existence for many years. They're very good at, they have pandemic plans at the regional level. So we've been working with them to update those and tailor those for what we know about this particular illness. But those healthcare coalitions are really the key kind of planning interface between public health and the healthcare system. So we're now really just refocusing and doubling in on what those coalitions need, and to make sure the information is flowing out to all of the providers in that region through the coalitions. Community mitigation planning, as I mentioned, has started and will be just positioning themselves to make recommendations to folks who have to make decisions about community mitigation strategies. The schools have been a very key focus for us, coordinating closely with the Minnesota Department of Education and also the Office of Higher Ed to make sure we're getting the best possible information on prevention and management out to those school settings. And again, the protective recommendations for the public, we just can't stress it enough, how much citizens can do to help themselves and to help us manage this community response. We all may not be at very high risk, but we owe it to the vulnerable people in Minnesota to do everything we can to contain the spread of this disease so that it doesn't have a devastating effect on our vulnerable populations. We can't say it enough. We'll keep saying it until you're really tired of hearing it, but it's just so important that people stay home when they're sick, with cold or flu-like symptoms. And we know that's easy to say and sometimes very hard to do for a lot of people. So we're trying to get our selves organized around what recommendations can we make to employers, local governments, et cetera, about how do you make it easier for people to stay home when they really need to stay home for their own protection, but also for the community's protection. Covering your cough, or your sneeze, learning the importance of not sneezing on your bare hands, but, using your elbow, things like that. Washing your hands really well, by which, and my mother just reminded me of this last night, the difference between running your hands under the water and using the soap and the hot water and really scrubbing down. And avoiding touching your face, especially your eyes, nose, and mouth, because this disease can transmit off of surfaces. We are doing everything we can to get good information out to the public and out to our key partners. The CDC website is just a really rich resource for recommendations tailored to various settings, and the MDH website as well. Right on our homepage, you can go right to the COVID-19 landing spot from the front page. So that was a really, really fast tour. Madam Chair, I don't know when you would like me to talk about the budget implications, if you want to do that now or after other testimony.
Thank you, Commissioner Malcolm. I do want to just make a recommendation on your update of this slide to not shake hands. I read
Not
that
shake
today.
hands.
Yeah,
Right.
we need to update that slide for
Yes, ma'am.
protective recommendations. Actually, I think what I would like to do is save that, because that is changing, I believe, as we go. I do have a question for you, and I know Commissioner France has to leave here soon. You mentioned the capacity. Now you can do the testing at your lab here in Minnesota, which is great, and you only have a limited supply of 800 for 800 people. Have they given you recommendations of what you should be prepared for, or is that constantly changing too?
In terms of the ultimate number?
Yes, guidelines as far as what to be prepared for as a state this size.
No, pardon me, Madam Chair. They've not, there isn't a formula yet that anyone has confidence in that would project, the amount of illness that we ought to ultimately be prepared for. We do have some planning assumptions about what we've seen about the degree of spread and the percentage of people with the illness who who have a severe enough illness to need healthcare resources. So we are doing some modeling with numbers that we're sharing with the healthcare providers about how many cases we might ultimately expect in Minnesota. And perhaps Ms. Erzman could comment on that a little further.
Thank you. And I think the reason why we are going to wait on the fiscal implications is because that is changing, and that's something that we'll probably deal with tomorrow. We have 3 really great testimonies coming up, and I'd like to make sure we're able to get those in. Senator Nelson, brief.
Thank you, Madam Chair. I just have a few questions for the Commissioner on this particular presentation. And, excuse me, and let me just start that we know that fear is more contagious than COVID-19 or SARS or MERS or even measles. So with that in mind, I have just a few questions that I know are on my mind that I also know are on my constituents, our constituents' minds. And so just a short little series of questions. And maybe I will list them to you all briefly, if you've got something to write them down so you can just answer briefly. I don't want to take too much time. But one question had to do with, as Senator Rosen mentioned, we do have one. I'm glad we have the ability to test in Minnesota now. And I understand there's a limited supply of 800 now. I have 2 questions in that regard. One, have the screening criteria changed? Originally, it was only if you had traveled to a particular country where there had been an outbreak, but now it's clear that COVID-19 is in the United States and, as you know, likely to come here. So I'm wondering if the screening criteria has changed since COVID is alive and well here on our homeland now. And then secondly, I want to know, whom are you waiting for to get additional test kits? Are these, who is the supplier? In other words, the supply chain for those kits? And then I just wanted to, again, ask one other question, which has to do with built-in immunity. I've read differing reports on whether or not there actually is an immunity with COVID-19. I think that's important to know. And I know constituents, I want to know how long, what is the life of a COVID-19 virus on a doorknob or a light switch, or how long can it live on a hard surface? I think that's important to know. And then, again, I just want to thank you. My questions are not about panic. We know fear is more contagious than any of these diseases, but it is about preparation. And this is at the top of Minnesotans' minds, and I want to thank Senator Ralph for taking the lead on this as far as making sure that we have funding necessary to prepare, not panic. And I want to thank the chair for holding such a timely hearing. This is essential, and I'm hoping you can provide some brief answers to some of those brief questions.
Commissioner Malcolm.
Madam Chair and Senator Nelson, thank you. They're great questions. I would appreciate it if Chris Ersman could join me to answer some of these questions. With respect to the testing criteria changing, thank you, Commissioner Franz. With respect to the test criteria changing, that indeed was quite specific at the beginning of the outbreak, focused on travel from China or contact with a person who's traveled from China. And indeed, those criteria have expanded and loosened, and we're being given a little bit more discretion by the CDC to tailor our approach to screening to be able to adapt to quickly changing community conditions.
Welcome, Ms. Sagersman.
Thank you, Madam Chair and Senator Nelson. Yes, the criteria have changed. So in addition to travel, which you know about, with first clinical symptoms in addition and a travel history, obviously also exposure to someone who has a confirmed case of COVID-19 is included. And then we've also added, or CDC has added, individuals who have very severe illness for whom no other diagnosis has been identified, regardless of whether or not they have travel or exposure. And what that is intended to get at is the potential for community spread. And as the commissioner said, we do have some latitude, and so we're able to do some additional testing. But given the limited tests that we have right now, we're being judicious in how we use them.
Ms. Ersman, can you please state your name and title for the record?
Oh, I'm sorry.
That's all right.
Madam Chair, my name is Chris Ersman, and I'm the Director of Infectious Disease at the Minnesota Department of Health.
Thank you. Commissioner Malcolm.
Madam Chair, Senator Nelson, your second question is, who are we waiting for to get more test kits? There's been a lot of work between the CDC and the FDA to authorize the production of more test kits. And Chris would have more current information than I on the speed with which we anticipate private laboratories being able to produce the test kits to make them more widely available. Our supply chain has been through the CDC.
Ms. Ersman.
Chairman Rosen, yes, we're receiving our test kits from the CDC. We anticipate that some of the larger laboratories may do what is called a laboratory developed kit. The FDA has made allowances for that. So we anticipate that other large laboratories will be developing their own test kits. Once that happens, they will be submitting specimens to our lab for double checking. So just like our specimens go to CDC initially, once we have a positive, they'll go to CDC for confirmation. Initially for other labs, when they do their testing, they'll go to the state labs for confirmation. Once that happens and they've been sort of tested out, then they will be able to do testing. And we anticipate that point-of-care tests will ultimately be available, but right now, all of these laboratories that have gotten the okay from FDA are starting the process, so we don't have that online yet, but we anticipate it coming.
Commissioner
Madam Chair, Senator Nelson, I think Chris could perhaps address the next two questions together. What do we know about any built-in immunity that there may be from other coronaviruses for COVID-19, and then life of the virus on hard surfaces?
Ms. Searsman.
Madam Chair and Senator Benson, at this point, we don't have good information, but we don't have any evidence to suggest that there is some cross-protection from other COVID infections. And the reason that I say that, or that I'll add a little bit, is that coronaviruses are a large family, and so you know that SARS and MERS are part of that family. But a third of common colds are caused by coronaviruses. And so that would suggest, with the frequency that we have colds, that there'd be a huge portion of the population that should have some protection if that was the case, and we're not seeing that.
Madam Chair, just one clarification, please.
Senator Nelson, we do, I just want to stress, members, we have 2 Rockstar other test virus coming up. I'd really like to get this done today.
Just a further
please.
clarification, thank you, Madam Chair, was,
Senator Nelson.
once someone has been exposed to COVID-19, do they have immunity? That was really the genesis of my question. There seems to be some uncertainty about that, and since COVID-19 will be in the communities for a while, we wanted to know that particular question.
Ms. Searsman.
Madam Chair, we're still learning about COVID-19, but I can tell you that Tony Fauci from NIH has said that he expects COVID-19 to behave like other viruses, in which case individuals would have protection once they've had the disease. And then the final question was, how long does the virus survive? Viruses can survive a while in ideal conditions. Doorknobs and tables are not ideal conditions. And so I'd say hours to a couple of days, and that's why we're encouraging people to do really good hand washing. You know, it's not so much that you touch the virus, but we want you to wash your hands frequently. That will get rid of it, and we want you to refrain from touching your eyes and other mucous membranes.
Thank you.
Thank you. If it's okay, Senator Franzen, can you wait? Okay, Senator Franzen.
Thank you, Madam Chair, and I'll be brief. It's tied to the testing. Just for the sake of clarifying misinformation in the public, we've seen in the news media talk about some tests that you can buy off the shelf or on the internet. Can you just address that, and also along the testimony that's coming up, if there's any misinformation that you want to address, please do so. Even though we are directing people to the CDC website, a lot of people don't go there. So if you can put it on the record, we'd appreciate that.
Thank you, Senator Franzen.
Madam Chair, Senator Franzen, thanks for that opportunity. There's always a lot of misinformation, you know, that the virus is, spread differently than it actually is, that it's more dangerous than it actually is. In terms of the test kits, there are none currently available that have been approved by the FDA, other than what is being distributed by CDC currently directly to state and large local public health departments.
Thank you. All right. I hate to do this to you, but I think Commissioner Malcolm and Senator Ralph, would you mind just stepping aside? Ms. Arisman, would you mind staying there? Thank you, because there perhaps might be some more questions for you. And we have Dr. Karani with he's the president and CEO of the Minnesota Hospital Association, and Dr. Beelman, Greg Beelman, Senior Vice President of Acute Care Operations for Minnesota, or mHealth Fairview, please. If you could come up. Thank you, Senator Ralph. Stay close. Thank you to you both for coming. I really do appreciate this. Yeah. Doctor, yeah, exactly. Who would like to go first? Dr. Karani?
Thank you, Madam Chair. First of all, I would like to thank the Madam Chair and all of the senators for the hard work you do in service of Minnesotans. I would also like to thank Senator Ralph for getting this discussion moving. It's a very critical and important one. My name is Dr. Rahul Khurana. I serve as the President and CEO of the Minnesota Hospital Association. For more than 20 years, I have been a physician in Minnesota. I have cared for patients and held leadership positions at Minnesota's smallest critical access hospital in Starbuck, Minnesota, and at one of Minnesota's largest healthcare systems here in the Twin Cities Metro. Over the past few weeks, Minnesota's health systems have been working very hard together to prepare our hospitals and clinics for patients and to support and protect our workforce during a coronavirus or COVID-19 outbreak. You will hear from one of our systems right after me. While COVID-19 is new, as Commissioner Jan Malcolm said, preparing for responses to disasters is not new to hospitals and health systems. Emergency preparedness training is a year-round activity that is done within each facility, each system, and each region. Hospitals and clinics treat patients with a variety of infectious diseases on a daily basis. These patients are isolated and treated in appropriate spaces by trained staff using specialized equipment. The Minnesota Hospital Association has been partnering with the Minnesota Department of Health to hold weekly information calls with our members and other healthcare stakeholders. We thank the Minnesota Department of Health for their leadership, particularly in the area of public health, disease containment strategies, and their communication to the public, like you just heard from the Commissioner. Our hospitals and health systems will play a central role in response to an outbreak. Based upon preliminary data, as you just heard from the Commissioner, we expect to care for the approximately 15% of coronavirus patients who will likely need hospital-level care and the approximately 5% of patients who will likely need to be treated in an intensive care unit or an ICU. So again, I want to start differentiating the public health response, the 80% of patients who will have mild illness, and the 20% of patients who will need hospital level of care. 15% medical surgical unit and 5% intensive care unit. Part of the Minnesota Hospital Association's collective planning is identifying needs so that hospitals and health systems can be prepared to treat a potential surge of patients. Hospitals and health systems are actively working on this together with the Minnesota Hospital Association. So with input from our members, the hospitals and health systems throughout the state, we have identified the following priority needs and areas. Number one, additional ICU capacity, medical surgical bed capacity, and isolation room capacity, and also specialized equipment such as ventilators or breathing machines. Number two, obtaining scarce supplies, including personal protective equipment, or PPE, which is critically important for protecting our healthcare staff who are going to be caring for these patients. Our care for patients in our communities depends on our hospital and clinic staff and care teams. These are nurses, physicians, respiratory therapists, and other healthcare professionals who surround the patients. We want to ensure that our nurses, physicians, and patient care teams have adequate PPE to keep them safe. Number three, increasing staffing to meet patient care needs, cover extended hours, and account for staff absences due to illness, school or childcare closure, or caring for family members. Number four, implementing systems to ensure safe patient flow and triage, including using phone banks, telemedicine, and to keep patients and families safe at home. So again, you heard from the Commissioner that we want to try to contain the 80% of patients in the community inside their homes. Number five, expanding bed capacity if necessary, including funding for additional equipment and physical facility changes. Number six, specific training for healthcare staff in all settings, specifically on COVID-19, pandemic preparedness, infection control and triage, especially in the light of growing supply chain shortages. I'm very pleased that testing for COVID-19 is finally available in Minnesota. Testing is critical so that we can get a full picture of the prevalence of this disease in our state. We also want to make sure that this testing becomes even more accessible in hospitals and clinics. Because COVID-19 is an emerging disease, as you just heard, and new information is being learned daily, we really don't have firm estimates at this time on the number of potential patients who may be needed to be hospitalized. But I'll give you some numbers. According to estimates from the Metro Emergency Preparedness Planners, Twin Cities metro area hospitals have approximately 5,000 total acute care beds and 500 total ICU beds. There are approximately 450 total ventilators or breathing machines in the metro. That could be able to be expanded to a degree using transport ventilators, anesthesia machines, and similar equipment. However, according to the Metro Health and Medical Preparedness Coalition, within the past week, available capacity for adult ICU beds, medical surgical beds, non-critical monitored beds, and airborne isolation room beds fell below 5% available capacity on one or more days in the Twin Cities metro. I do have numbers from yesterday, and several of these critical bed areas, including ICUs, are below that 5% available capacity number. It is critically important for state policymakers like all of you to understand the needs of our healthcare delivery system to deal most effectively with this contagious disease. State resources will for sure be needed because we don't know how much will be forthcoming from the federal government or when. We urge the state legislature to swiftly provide supplemental emergency funding directly and specifically to support the urgent preparedness and response needs of Minnesota hospitals, healthcare systems, physicians, nurses, and care teams on the front lines of this outbreak. This supplemental emergency funding request from Minnesota's hospitals and healthcare systems and care teams is in addition to the other COVID-19 preparedness and response efforts the state is considering funding, including public health measures, surveillance, lab testing, and other efforts just outlined by the MDH Commissioner. Minnesota's hospitals and health systems will work hand in hand with federal, state, and local governmental partners to ensure safe care for patients, protect healthcare professionals who are providing patient care at the front lines, and support the health and safety of our communities. Regardless of size or geography, our frontline care teams, our nurses, our physicians, our other care team professionals who will surround these patients need to have all the tools at our disposal to serve Minnesota. Thank you for your consideration of our comments. We, as always, stand ready to serve our communities across the state. Thank you.
And if you wouldn't mind, members, I think we'll have our testimony from Dr. Bielman, and then and any comments from Ms. Erisman that she'd like to finish up with, and then we can follow up with questions. Good morning. Thank you for coming, Dr. Bielman. Please state your name and.
Madam Chairman, thank you very much for the opportunity to speak to you folks this morning, and senators, thank you for your attention this morning. My name is Greg Bielman. I'm an intensivist and surgeon at the University of Minnesota, where I've practiced for the last 25 years. I'm a professor at the university as well, and I've had the honor of serving as a reservist in the U.S. Army, where during one of my 5 deployments, I served as the chief of trauma for CENTCOM in Iraq and Afghanistan. I'm here today to talk to you folks briefly about the potential impact on COVID-19 on both our academic health system and our flagship medical center. My comments fit very nicely on top of those that have been made by the Commissioner of Health and my colleague, Dr. Karani. At the University of Minnesota, we are focused on caring for patients in the state of Minnesota. We serve as a major referral hospital and arguably one of the most important referral hospitals for the people of our state, and have educated more than 70% of the healthcare practitioners in the state. We are actively following the science, epidemiology, and latest information from the CDC, and coordinating closely with state and federal health officials, initiating a mHealth Fairview Hospital Incident Command System that's there to prepare and respond to COVID-19 infection and threats. During the Ebola outbreak of 2014, we became one, and with support from the state, we became one of 10 human health HHS designated regional treatment centers with the responsibility to be prepared for and to treat high consequence infectious diseases like SARS, MERS, and coronaviruses like COVID-19 that we were talking about today. We're responsible for treating patients with these highly infectious diseases from Minnesota and other states in our region. We actively are training and equipping our staff properly to safely care for these patients and other cases where COVID-19 has been confirmed. We actually at this point have 2 patients who are persons under investigation for COVID-19 in our system. Our team is ready in diagnostics, supplies, and treatment methods for these patients, and we remain in constant conversations with the CDC, the Minnesota Department of Health, and other health systems and organizations, including Dr. Karani's organization. As everybody has mentioned, this is a fluid situation. We don't know how many of these infections we'll have to deal with. We don't have any clear signs of how severe this outbreak will be in the United States as compared to China. However, as Dr. Karani and our commissioner have already noted, about 5% of patients with COVID-19, and importantly, up to 20% of those over the age of 70 will require advanced ICU care. Senator Nelson said this is not about panic, this is about preparation. Now is the time for us to be preparing. Related to what Commissioner Malcolm noted, COVID-19 will be affecting Minnesota and will be affecting the people of Minnesota in the near future. We need to have the right people, the right equipment, and the right assets in place to take care of them, which includes specialized equipment and strong teams that know and have trained to deal with special pathogens. To do this and to care for the tip of the triangle, if you will, those 5% of patients who will require critical care, we will require significant resources to care for those patients effectively, because as Dr. Karani noted, we are all running at high capacity now because of the flu season. And there are a number of specific equipment needs that we will have to care for these people effectively. I want to bore you a bit with a couple of definitions before I talk about our equipment needs. The first of these is acute respiratory failure. Simply put, this means that your oxygen is not able to get into your bloodstream because your lungs are not able to exchange carbon dioxide for oxygen. In this case, we put people on a ventilator. This is a machine that blows air under pressure into your lungs to improve oxygen exchange across the alveoli, the little air sacs in the lungs. Many people who get severely ill with coronavirus will need ventilators, and Dr. Karani has already spoke to that need. And many of these people will also develop a condition called acute renal failure, which is shutdown of the kidneys. Kidneys no longer make urine, and then we need to have a machine to help clear the toxins from the bloodstream in these patients to preserve their lives. Finally, there's a new technology with the name of ECMO. ECMO stands for extracorporeal membrane oxygenation. ECMO is a way to treat people who have had respiratory failure that's progressed to the point that we can no longer treat them with a ventilator, which is our standard technique. ECMO is one of those things that came out of the work that was done by soldiers and military doctors in Iraq and has been used much more successfully in people of the state of Minnesota. People that 10 years ago I would have said were going to die, we are now able to put on ECMO and have 70% of those people survive and go home to their families. We will need more help with ventilators, respiratory or ECMO equipment, the things that support the ECMO equipment, and continuous renal replacement therapy equipment if we are to care for that top 1% or so of the patients who come down with COVID-19. I've appreciated the opportunity to testify to the senators today, and thank you, Senator Rosen, for the privilege of the floor.
Thank you, Dr. Beelman. Senator Ingebrigtsen, you have a question? Okay. Yes, we are actually opening up questions.
Okay, I just got a couple practical, practical questions. The information that we have now is the fatalities that are occurring in Washington State are contained somewhat in a nursing home. How would that look? How would that system look coming and going if that were to be here? How would you contain that? And my last question is pretty practical as well, that if you have somebody that you know has the virus and refuses quarantine, what authority do you have, or what authority do we need to give you or to be able to detain somebody like that?
Ms. Earsman, can you answer those questions?
Madam Chair and Senator Ingebrigtsen, I'll start with the question about quarantine first. The commissioner does have the authority to isolate and quarantine individuals for infectious disease. In all the years that I've been at the agency, we have never had to go to court to institute that. We have always been able to receive cooperation from individuals. So in other words, people aren't thrilled when we explain what's necessary, but we have always had cooperation. But if needed, we have the ability to isolate someone who has a disease or to quarantine someone who has been exposed that we're concerned about. We have a limited time frame, so we can take action immediately, and then we need to go to court to make our case. And so the point there is that we're both protecting the public's health as well as ensuring that individual rights are preserved. And then to the other question about containing the virus in, say, a long-term care facility, we are currently with our community mitigation groups, the group that's looking at how we can make recommendations. We're looking at the recommendations we would make to those type of skilled nursing facilities. I think that one of the things that we would look at is if we have a situation like that, obviously we would not be moving patients around, we would not have visitors, that type of thing. So the goal would be to limit any sort of outside contact with the facility, but that we would make sure that they have the resources that they need. And clearly, if we have somebody who needs hospital care, then that's another situation in terms of transferring the patient. But
Dr. Karani.
Thank you, Madam Chair, and thank you, Senator, for the question. All I would add to what Ms. Earsman said is that we have had several nursing homes or skilled nursing facilities on our weekly calls with the Minnesota Department of Health. And over this last weekend, we worked, from an MHA standpoint, worked closely with the association, the largest association of post-acute care providers across the state called Leading Age Minnesota, and they convened a meeting right on Sunday to start preparing. So we are very much thinking about long-term care facilities and other facilities like assisted living. But to what Ms. Earsman said, we do need to think about if there are a lot of cases in one facility, we will need to think about if they come into the emergency department or into the hospital and how we contain that between the nursing home and that local hospital or a tertiary hospital if needed. So that is part of what we are thinking about. Thank you.
Senator Cohen.
Madam Chair and Dr. Karani, in your testimony, you emphasized the preparation with metro hospitals. What happens in small rural hospitals? Are they equipped to handle something like this, or would a patient be transported to a metro hospital?
Dr. Karani.
Thank you, Madam Chair. Thank you, Senator Cohen, for that question. We are absolutely thinking about all the healthcare systems across the state. Day before yesterday, I convened a call for all of the CEOs from all hospitals across the entire state outside the metro. And there were hundreds of CEOs and their care teams on the phone. So for those facilities, we would be working, and we are recommending working with the 8 regional coalitions that are supported by the Minnesota Department of Health. We are actively looking at the capacity and capabilities in the smallest of the small health systems, what ICU or critical care capacity they would have, their staffing needs so that we can keep the nurses, other professionals, care teams safe there, and what type of patients they can safely care for in their facilities, and when would it be required to transfer the patient to a secondary or tertiary hospital. There are many considerations in that, including the EMS providers and their exposure, the ability to have ventilators in the facility in outstate Minnesota versus in the EMS. So all of that is being considered, but rest assured that from a Minnesota Hospital Association standpoint, we work with all healthcare systems across the state, not just the metro in the 3 metro areas in the state, but also with all the critical access hospitals in the state. So definitely that's top of the list as well. Thank you.
Senator Cohen, I could add to that, too. I was just on Saturday at my community hospital, critical access hospital in Blue Earth, little community of 5,000, and they are definitely re-grand opening of their emergency room. They are definitely, this is definitely on their radar, and I'm glad to hear that there's communication for these small communities. Senator Limmer.
Thank you, Madam President, Madam Chair. Sorry about that. My question is more directed to the bill itself and the money that we're talking about. How much money is currently in the contingency fund now?
Senator Limmer, I think we should probably have Commissioner Malcolm come up to answer those questions.
I can hold.
Okay, we are laying the bill on the table.
All right.
And then if we have more time after, there's a few more that have some questions, we can get to that, but we definitely have to talk about the money at some point, so. But Mr. Nauman has an answer for your question right now. Mr. Nauman?
Madam Chair, if I'm reading the body language, I think it's 4.6 million?
Yes.
Is the balance in the account?
And Mr. Nauman,
Senator Limmer.
we're being asked to add $5 million to that dollar amount.
Mr. Nauman?
Madam Chair and Senator Limmer, the proposal in front of you transfers $5 million from the general fund into the account.
So then it'd be roughly a little
Senator
over
Limmer.
$9 million.
9.6.
And the question that
Senator Limmer.
that I'll lay out, and we'll hope for an answer, is that going to be enough? And we can answer that at a later time.
Thank you, Senator Limmer. That's great. Senator Nelson.
Oh, thank you, Madam Chair. Well, I just want to state that I am so glad to live in Minnesota that has a history of strong public health. This is going to be incredibly important, and I just thank the leaders for being proactive on this, particularly the community mitigation calls that are taking place, I think are incredibly important. I knew about the schools. I think that's obviously could be ground zero, very important. But I'm glad to hear about the same type of calls with our long-term care. One of the things that I sense is going to be very severe, and maybe this is, or shouldn't say severe, could be, that I think should have special attention, are the senior communities where seniors are in congregate settings, maybe not even assisted living, maybe just they go to exercise every morning and they might go and play bridge. It's a very small, kind of like a small cruise ship, so to speak. And so I think those particular facilities are certainly should be part of these community mitigation calls as well. And I think of some particular, if we don't have a list of those, I can definitely tell you some that are in my neck of the woods. And then to Senator Limmer's question too, well, first I want to thank Senator Ralph for being on the forefront of bringing this to us, but then to this issue of quantifying the dollars. And at some point, we do need to get some sort of idea about what we expect for, as Dr. Corain mentioned, all of those essential items, and how do we realistically provide for that. So we'll look for I'll look for more details on that budget and what's needed. So thank you.
Thank you, Senator Nelson, and that is the reason why we're not able to finish this Senator Ralph's bill today is Senator Benson, and she has been very much the point guard on all this, coordinating with the departments and the various needs from the hospital association. So that's why this bill is coming up. It'll be laid on the table, and it'll be coming up tomorrow morning. Senator Westrom.
Thank you, Madam Chair, and back to the virus. You mentioned part of the plan would be 80% of people that become infected with this type of coronavirus flu may not even have severe symptoms. It's the 20% then that have much more severe symptoms. So as I've tried to study it myself and listening to you and the public that's trying to not over-focus on this but be concerned and cautious, how do you go ahead and determine if somebody's going to get worse symptoms, or do you not have a way to tell that ahead of time and you have to just send them home and say if symptoms get worse, call us and then we might hospitalize you? And the reason I'm asking that is what are the threats of serious injury or death beyond what the normal flu is, if there's any difference? And how do you make that determination as you're trying to decide if somebody should self-contain and go back home, or you hospitalize them, or what's level of severity? Because the 80%, if I'm hearing you right, may not be affected real bad, or not much different than the common cold or common flu that every one of us has gone through at times.
Dr. Karani?
Thank you, Madam Chair. Thank you, Senator, for the question. I think you've got a panel with a primary care doc, a specialist, an epidemiology leader, so I think we'll try to kind of tag team. But from a community perspective and the primary care ambulatory clinic perspective, that's one focus that I'm seeing the Department of Health, and we're pushing this out too, trying to connect remotely with your clinic so that, you know, the clinic providers can help you decide if you even need to come in and in the level of illness that you have, so that we reduce the amount of exposure. If the clinic providers over telemedicine or phone think that you need to come in, then and you have a travel history or you've been exposed, and so there's protocols in place that came from CDC that MDH is spreading that we have. If the Minnesotan needs to come in, then, you know, protocols about testing, isolation will go into place. The patient will be assessed, and then can you be taken care of safely in the clinic? Can you be sent home safely to your home in quarantine? Versus are you sick enough to be that 20% that you need to go into the hospital, a medical surgical bed for the 15% or so, or in an intensive care unit with a breathing machine or other specialized equipment for the 5%. So, you know, this is where public health, the Department of Health, the primary care, ambulatory care teams, other resources like EMS, they all need to be coordinated and working together. And again, in Minnesota, we're blessed to have a robust system. The volume of the cases that we could see during a surge, you know, could actually go beyond what, you know, we might have in our clinic or in our hospitals. And I think that's the urgency that we're trying to bring to you today. But hopefully that gives you a picture of how we would assess and treat.
Madam Chair, and thank you.
Senator Westrom, I think Ms. Erisman wanted to reply.
Oh, great. Go ahead.
Madam Chair and Senator Westrom, I do want to just let you know that we have a team at the department that basically a provider hotline, if you will. So we have staff that are, a number of staff that are prepared and ready and taking dozens and dozens of calls from providers. So as Dr. Karani said, when the provider gets the patient in and they're doing the assessment, then they will call us to help them go through the evaluation based on clinical, epidemiologic, and travel history. And then we can make a recommendation for testing. As you've heard us say, 100 times, 1,000 times, probably more than you want to, our recommendation for anyone who's sick is to stay home. And so even if the individual does not meet criteria for testing, we still recommend that they stay home when they're sick so we don't spread any respiratory diseases. Thank you.
Senator Westrom?
And Madam Chair, thank you for that. And some of what I'm trying to square in my own mind, as constituents talk to me about this as well, is 2 weeks ago or 3 weeks ago when kind of the panic seemed to be quite elevated. And, you know, my first thought was if this hits, people are going to die in masses. And that's kind of been tamped back quite a bit. It's maybe a hard flu, but it sounds like most people survive it. And what I'm hearing from you today is that's a lot of what is still recommended. It's going to be self-diagnosis, but if you have a flu or common cold fever symptoms, it's really hard to say whether you should just stay home and get over it or go in. What would a person do, and what would you do to treat it? Does it run its course, or do you want to take some certain medicine that's going to stop the corona flu virus quicker? What kind of treatments are there, or is it realistically just handle it like we've handled the flu for all the years we've all lived?
And also, if I could, Senator Westrom, add to that question, is this something that as the temperatures warmed up outside, is this going to become less of a factor? Dr. Karani.
Thank you, Madam Chair. I'll begin the answer, and the more public health treatment, I mean, there are experts at MDH that can help with that. I think the reason to have this conversation, why I'm appreciative, is if you look at the graphs that the commissioner showed, we need to be prepared for a surge. I think that's what this is about. If there's a surge, and if our ICU beds and our medical surgical beds and our isolation beds are in short supply, within the last week, the available capacity was under 5%. We do need to think about the 80% where we will do the public health management, but we have to ensure that the Minnesotans that require intensive care and hospital level of care have access to those beds, have access to the ventilators, have access to our specialized care teams and staff. So I think that's what I'm hoping that you will discuss. And does it look like a contingency emergency fund where that you create? Part of it could be public health funding that has been articulated, but part of it is specifically for the healthcare systems, the hospitals and the clinics that are going to be at the front line of this sickest of the sick. So I hope that will be something you will discuss and consider and decide. Thank you.
And Madam Chair, in terms of seasonality, we don't have information yet if this virus will play out in a seasonal manner, but it is true that other diseases have seasonality. Other viruses that we see circulating have a seasonality to them. So that remains to be seen as we move into the warmer weather. And then just what we're telling individuals that call the health department in or wondering what to do is that we say, if you would normally seek health care in this situation, then definitely you should call your provider. Please call in advance to say that you have upper respiratory symptoms, and so that they can mask you if that's appropriate. And then, ask the healthcare provider to evaluate them. We do not feel that every person that has upper respiratory symptoms needs to be seen in healthcare, and we want to make sure that our healthcare is reserved for those individuals who are at highest risk. And so even with our recommendations for influenza, we say if you're a person who's in a high-risk category, so has an underlying health condition, elderly, those are definitely individuals that we want to make sure are seeking care. But if you're, normally healthy, you've got some upper respiratory symptoms, and if COVID-19 wasn't in the media, you wouldn't think of calling your provider. We're not suggesting that you change your practice now.
Okay, thank you.
So, Madam
Senator Westrom.
Madam Chair, last point or question. So what I'm hearing is your symptoms could be as mild as the common cold, upper respiratory, plugged nose, harder time breathing, be similar to those symptoms. But it may get into the vomiting and the other unpleasantries that go with the flus, but not all of them are even going to result in that. Am I accurate in saying that? Or does everybody run through the actual flu symptoms and vomiting and run the whole gamut?
Ms. Ayersman.
As part of it hits.
Madam Chair and Senator Westrom, yes, most people will have mild symptoms, as we said. I want to just clarify that when we're talking about influenza, we're talking about upper respiratory illness, and COVID-19 also upper respiratory. So a very small percent, like 3% of patients may have had some gastrointestinal symptoms, but we're not talking about vomiting and diarrhea as the predominant symptoms here. We're talking about upper respiratory symptoms. And yes, most people will be able to, stay at home and be okay. But we want to make sure that individuals who are in high-risk situation, high risk for complications, are checking in with their healthcare provider. And again, if it's something that you would normally check in with your healthcare provider on, we're not suggesting that you not do it. We just don't want people to feel that just because COVID-19 is in the news, that now they need to check in. And I'll turn it over to Dr.
Beelman.
Beelman.
Dr.
Madam
Beelman.
Chair,
yes.
Senator Westrom, I have nothing to add to those thoughtful comments. Thank you.
Okay, all right. And Ms. Ayersman I really didn't give you a chance to testify. Was there anything else that you would like to say about this?
Madam Chair, no other than thanking the committee for being interested in this topic, and we're happy to answer any other questions that may come up after the hearing.
Well, thank you very much to all three of you, Ms. Ayersman, Dr. Karani, and Dr. Beelman for being here. It really means a lot. I think this hearing was the first step in our preparation. We are continuing, as I have said, Senator Benson is the point guard as far as the communication. Senator Ralph, thank you for your work on this. Very important. And the more we know about it, I look at this map from Commissioner Malcolm. It's not a matter of whether we're going to get missed. It's a matter of when it's going to hit our state. So we are definitely getting prepared. So I appreciate all your work on this very much. With that, we will be laying 3813 on the table. Thank you. Members,
Thank you, everybody.
meeting is adjourned.